The purpose of the Global CFO Council is to provide an educational and networking forum for senior financial executives in order to share best practices, discuss current financial issues, and to learn about current topics related to the performance of their jobs.
Good morning, everybody. I'm glad to have Frank and Chelsea this morning. Chelsea, I don't know if Frank told you, but I don't read bios. I just find stuff on the internet about you. Did he reveal that to you?
He did not.
Okay. So yeah, that's just sort of a fun thing that I do. So it's light. I don't have a lot on you, which is amazing because as a young person, I thought I'd have to cut for time, but you have a low profile. So it actually made me think maybe Frank gave you a heads up. But we'll keep this short because I have so much on Frank.
Yeah, there you go.
Chelsea Thomas is the practice manager at Holy City Med, handles, among other things, operations, sales, marketing, and human resources, which is pretty much everything. So it makes me wonder what Frank is doing.
We have the same question, Robert.
Chelsea, I believe you're a USC fan. Is that correct?
I am a USC fan, but I went to college at Charleston, so did not graduate from there. And I spent 7 years with Frank at Health First, so that's how we know one another. It's a long time.
It's like a prison sentence.
Now we're here.
My God. Are you from Hanahan?
I am.
And this is super dangerous. Are you engaged?
I am.
Oh, thank God. All right. Okay. That always really scares me. Okay. I'm going to cut for time, Chelsea. I have much more.
Absolutely.
Frank Wells. Are you the founder and CEO of Holy City Med?
Yes, sir.
Are you also the co-founder of Renew IV Spa?
Yes.
CEO, COO, 20 plus years in medical supplement, apparel, etc. Lots of different industries.
Yes.
Also, were you a senior leader in charge of all volunteers at the 1996 Olympic Games in Atlanta?
Your wife can confirm that. She still idolizes me.
That's not what she says, but my wife was a volunteer. I think you were like 50 and she was a high school student, so she just remembers this really old guy is what she told me. Do you owe my wife some Olympic pins that you've promised her and still have yet to provide?
That is correct. And I was in my 30s during the Olympics. So there you go.
True or not? Did you also either found, own, or partner in footrubguru.com?
Foot rubs are heavenly. Yes, I am.
Frank, I think you got your undergraduate at the College of Charleston. Is that correct?
Yes, we are currently undefeated in football.
And speaking of job history, Frank, something interesting I think I know about you. While at the College of Charleston, were you the Coors beer rep for the College of Charleston?
Yes, and they paid me to promote beer on the college campus while I was in school. It was a pretty good job.
You peaked at 18. Wow. I think because you could drink at 18 back then in the 40s, right?
Exactly. Yeah.
MBA from the University of North Carolina, Chapel Hill.
Tar Heels.
I think are you a South Kakalaka native?
Yeah, my mom still lives in the same house, West Ashley, where I grew up. Pretty cool.
Frank is a super volunteer in South Carolina, where he lives. Some things include, I think, Marketing Association Center for Women, Rotary, and Seacoast Church. Is that correct, sir?
Some of those are still accurate. That was an old bio. Wow.
If I find it on the internet, I read it. Married with 3 kids.
Yes.
And is this true? Did you go to Porter Gaud High School?
I did when it was affordable.
Did you play soccer?
Yeah, we won the state soccer title when I was a junior.
Bam.
Yeah.
Good people. Don't put stuff on the internet you don't want me to find out. And then I'll close. I think you're into the outdoors. I saw kayaking, tennis, and some fishing. Is that true, sir?
Yeah, we do some fun stuff. I'm not an outdoorsman like those crazy guys, but we grew up water skiing instead of hunting.
Hey, yes or no is fine. You don't have to go on and on and on. All right. I'm cutting this for time. That was awesome. Chelsea and Frank, we're lucky to have you. And this is a special twist, folks. I have a personal interest in this direct primary care and these near site facilities. I just think this is an interesting emerging thing. I have lamented with Frank before. It feels weird. It seems like over time, the 20 years I've been an accountant, Frank's got 50, 60 years of business experience. But in my mere 20, it seems like I'm paying a lot of money to just have the option of spending more money for healthcare. It's very weird. I don't feel like I even have insurance anymore. I just have, it's like I'm paying a really expensive fee to be in a club to later on pay a lot of money. So it's just weird. Frank is a practitioner. He's a serial entrepreneur and a practitioner in this area. And I was just like, Frank, can you kind of coach us up? So this is my personal interest, and the rest of you are here just while I get educated up. And lucky to have Frank and Chelsea. They're in this biz. So I'm going to mute myself and just hit you with questions when you stop, Frank.
Okay, good. How's the volume, Robert? Because I can increase or decrease the volume.
I'm sorry, are you talking?
Yes.
You're good.
Okay, cool. So we'll just talk briefly about healthcare overview, a little history. We'll reference some terms and some solutions and what's changing, developing in the scope of healthcare. And like you said, Robert, specifically direct primary care. If you like to use Google while you're in a presentation, DPC is now a very common term that stands for direct primary care. And then we'll also do a little bit of information on a case study with Gerald's Tires here in town locally that most of you have heard of. So, and healthcare, I'll just say this, people say they kind of interchange the word healthcare and health insurance. They're obviously two different things. Healthcare is the providing of medical services to individuals and staff, and health insurance is that which sort of covers you when something crazy happens. And, there are different coverage levels of that. So I just want to take us back in time a little bit. Imagine 10 years ago, if the slides are going to move there, could be user error. Let's see, Robert. Anyway, so 10 years ago, we paid our copay when we went to the doctor. Hopefully people remember that. And we never got another bill. We just paid that $20 copay. It was even as low as $10 a decade or so ago. And never got another bill. And while most insurance companies still cover preventive care visits in their plan, there are some exclusions related to deductibles where the insurance company no longer pays the balance on that bill from your doctor visit until you've met that deductible. And so that's been the big change over the last decade is hopefully you all remember you paid your copay and that was it. Nowadays, we hear people say quite often, oh no, I just paid my copay. And I typically will say, well, what about 30 days later, that thing you get in the mail? Oh, that's from the doctor. So the doctor's looking for more money or something like that. And it's for most people, it's simply an exclusion in the insurance policy that says we cover you for preventive care needs, but financially we don't jump in until you've met that deductible. So so it gets a little challenging for folks and increases their costs, right? Makes people not want to go to the doctor as often. When you do, the all-in cost, urgent care center is about a $50 copay, sometimes more, sometimes less. And then we typically get a bill about 30 days later with most plans of another $200. So you're paying about $250 out of your pocket. And the real challenge is, again, that employees don't go to the doctor because who wants to pay $200 and $250 for somebody to say you have a cough? I already know that. Just give me something that helps me sleep at night so I'm not coughing my way through the evening, and then my body heals itself while I'm sleeping, so I feel better. And then you've got premiums on top of the doctor visit, right, using your insurance plan. And so these are typical monthly premiums. Now, the employee doesn't pay all that $400 to $500 a month. Usually the company pays about 80%, somewhere around 80%. The national average is 82% for most larger companies, and the employee pays the remaining 18 to 20%. If you have family coverage, that's going to be about 3 times or more to add your family to that coverage. And oftentimes it can be a total cost of about $20,000 to $25,000 per year. We've had very stagnant wages in the U.S. since about '03, and most believe that this is partly because of the benefit costs. We know as employers we've been paying people more money, but if it doesn't show up in their wages, in their hourly wages or their salary, it's typically in their benefit costs that we still bear. So. And the other thing is so paying the monthly premiums, it does cover, like I said, those preventive care visits, but outside of, if you haven't met your deductible yet, and it's not your one annual visit that's included in that preventive care, no out-of-pocket plan with most insurance companies, you're basically self-pay. And so when you relate to the deductible in your insurance plan and realize that if you're in the 1 out of 20 that hits your deductible, it's kind of like celebrated in a way. Yes, I've hit my deductible. Now I can go get all kinds of things done that are medically necessary. If you go in for things that are optional, that's not always covered under your insurance, so the medical necessity matters when using your insurance plan. But most people, 19 out of 20 insured folks, don't hit their deductible every year. Even if you went to the doctor today for some back surgery or knee surgery or something, and you hit your deductible this year and you thought, what else can I get done? But you've got rehab and you have some things that are going on post-surgery that you have later today. And you're so excited you finally hit your deductible, and then you realize that your rehab is going to go into the next year, and that deductible typically will roll over every year, and January 1 you might start over. So it's kind of a celebration and not a celebration. Most people have a deductible of $3,000 to $4,000 or more nowadays.
Hey, Frank,
So,
I got a question to just sprinkle in here early I wanted to hit you up with.
Yeah.
It's just around definitions. Could you speak to kind of compare and contrast direct primary care to concierge versus urgent care? Like how I see centers that say urgent care. Sometimes I see somebody who says they're starting a direct primary care, and then you read about concierge service. Could you just define those things for us, please?
Sure, absolutely. So direct primary care, or DPC, is just taking the third party out and getting that relationship between the doctor and the patient directly, both from a treatment standpoint. So there's no hurdles for, do I need a prior authorization for something? And the financial relationship is direct as well. And concierge is part of that. So the concierge, I don't know if anyone remembers Prevacare that opened on Daniel Island like 15, maybe even 20, over 15 years ago. Dr. Bright McConnell opened that plan where it's concierge medicine. You're paying $4,000 to $6,000 a year. You could go as often as you want. You had this great, huge diagnostic test done for you. And it's really for the higher income earners, that concierge type medicine. It's come down from that $4,000 to $6,000 a year to about $2,000 a year. Typically, the doctors will charge you $150 a month or more, and it includes some things and doesn't include others. And then direct primary care, what I described is just a direct relationship. Urgent care is a whole different type of thing. We combine them, urgent and primary care, together because the same provider can do the same work and not have a patient have to go to 2 separate visits with 2 copays and 2 bills and that sort of thing. But urgent care is also can be a direct relationship, but most of the industry in urgent care is a insurance payment type of relationship. It hasn't really, the direct primary care, the direct pay model hasn't really hit urgent care as much as it has primary care. So good question.
Thank you.
And I am in the area of where I've got the terms and everything as well. So good timing. I'll just back up for a minute. We did some studies to sort of create this model. And obviously Health First was a study. I was there for 12 years as a CEO, and we were seeing a tremendous amount of patients per year, about 150,000 annual patient visits, and learned a lot about the industry and the cost and the efficiency, and very efficient model that Dr. Bo Machado created. We were processing insurance payments from 640 different insurance companies. And so just think about that. It becomes expensive anytime you have to process or file a team of people to do that. There's also some front end hurdles with contracting with the insurers that were paying us through Health First. Every provider had to be credentialed or registered with them. So there's all that to say there's just this large process involved with accepting insurance for each and every insurance company. There's some bulk benefits where one group will take care of half of those insurance companies, but literally 640 different insurance companies, we accepted payment from them, processed, and then defended claims against audits against some of those payers as well. So we found out through all of that about half of the cost of providing medical care to people in the urgent and primary care space was simply accepting, processing, and defending those insurance payments, those claims, and then sending out statements and everything too. So the self-pay, direct pay model was tested with us first with Renew Medical that you mentioned, the IV clinic that I have on King Street. Almost 5 years ago, we opened that to simply, and with the help of Dr. Machado, he said, let's test out the self-pay model. We did, and it worked tremendously well. Still open now. We haven't closed it all because we're medical, which is nice to be in that necessary space. And then the direct primary care piece, we go to, most of our research was done in the Midwest. So Kansas, Wisconsin's had direct primary care clinics for 8 years now. And you can find them scattered about the country. I know we have some folks on here from the Upstate. If you Google DPC, or if you use a portal like Vitify, it's VITAFY, Vitify Med, Vitify Health. You can go and look for DPC or direct primary care clinics in your local area, because we're just in the Charleston area right now. Under the urgent care space, not only Health First research and our knowledge there, but Doctors Care. One of the docs that works here was the medical director at Doctors Care for 17 years, and then worked with us at Health First as well. Nason was a model that was in town, is back now. Care Now is part of Trident Hospital and that large group, Roper Express Care. So we've done a ton of research with those, and then the on-site clinic. So the other topic besides direct primary care was near-site medical clinics, right, Robert? So that's in comparison to on-site medical clinics. When you think of on-site medical clinics, you think Boeing, you think really large companies. Denton Shipyard, Lloyd Stewart had a heart to have medical services on their facilities. for all those folks working on the docks, on those large vessels. And so for years and years, Denton Shipyard has had an on-site medical clinic. And the research we did on them is it's a great service to offer. It has a fair amount of liability on the part of the company because they build and own that facility. They also have higher costs per patient visit. It's about 2.5 to 3 times the cost to run that clinic yourself because you have lower volume. And you're open for less hours typically with an on-site medical clinic, which means only the employees typically have access, and the employees' dependents, spouse, and kids don't always have access to an on-site medical clinic. They do with the Boeing plan through Roper, but through others, most of them, they don't. So it's just for the employees. And we thought, how it'd be cool to lower that cost, to share the overhead amongst many companies and have it near their business, not on-site, but near-site medical clinics. And you almost get rid of the liability altogether because now the company doesn't own that medical clinic and have the liability of what happens if somebody gets hurt and so forth, medical malpractice. You get a way more privacy. You don't have any C-level folks looking into medical records of staff, which is not allowed with HIPAA. But not allowed doesn't always mean that it's full protection there. And then you get that access for family members and dependents when you use a near-site type medical plan. So I just boiled down all the research we did to hit that area of direct primary care and the near-site medical clinics. This was sort of my stopping point to see if anybody had any questions there in the chat box. Any other?
I do.
Yep.
One question is, what should we consider when you say near site? Like, what's an appropriate radius? If I'm trying to figure out a facility near my site, and how near is near?
No, it's a good question. Yeah, and what we found is that traffic patterns are often more important than the distance from the workplace. And so traffic patterns would be between work and home. Right? So as long as you're in that traffic pattern between home and work, because sometimes people don't feel great first thing in the morning and they're not right next to work. They may be 10 miles away from their workplace. And so it's just to be in that traffic pattern. Our first 2 clinics are right off 526. We know that there's a significant portion of folks that hit 526 during their workday, their commute to work and home. So that's been more important from what we've found. Some people will ask that question, I want you to be 2 miles from my clinic. Well, where do your people live? So it matters where they live. It's funny, all the folks a lot of business owners in Mount Pleasant, they'll say, let us know when you get a Mount Pleasant location. And we say, well, where do your folks live? And they don't all live. Their employees don't all live in Mount Pleasant. So our newest one that opened next month on North Rhett in 526, we call it our Daniel Allen location because it's only 5 miles from Daniel Allen. So.
Next question is, how do direct care or DPC and or near site, how does that, or does it meet the needs of employer mandates under Obamacare?
So that depends on the size of the company. So if you have 50 full-time equivalent employees or more, then you're required to meet the mandates of the Affordable Care Act, one of those being minimal essential coverage. And so the short answer is direct primary care can be part of your plan. You still have to meet those requirements for minimal essential coverage that can be done through insurance plans, traditional legacy type plans that we're all used to, that we had at Health First for years as well. And they can also be met through more innovative type plans that use direct primary care, that might use medical sharing plan, some sort of catastrophic care that's kind of on the screen right now, and uses an ICRA, a structure called an ICRA that's a reimbursement account. So there are ways to do that to meet the standards from the government as well and still have direct primary care. Chelsea probably wants to say a few things.
Sort of like a combo where you maybe have a high deductible plan, but your employees have the ability to go to a primary or a direct primary. I'm just going to say DPC. I can't say that to save my life. Goodness gracious. Okay.
The other things too, Robert, the larger companies, when they get to a point when they're large enough to self-insure, so they take all the premiums they would typically send to an insurance company and they put it in their own account. They want to make sure those funds are there when somebody does have a catastrophic or hospital surgical need. And so they are finding they love direct primary care because it gives their employees access to go when they want to. They don't avoid the $250 visit. They have basically no cost in going to the doctor. Even if it's a video visit, they can just log in and connect with a doctor and find out what's going on. Certainly during this time of COVID, when if you cough in the grocery store, people run away from you, like when you turn the lights on and the cockroaches scatter. But so it is an important time now to make sure that someone just has a cough, just has the flu, just has strep, instead of having COVID and having to quarantine and all the CDC guidelines there. So, but self-pay, the folks that use self-insured, they love it. They want to keep people healthy through the preventive care model and not just use insurance when you go to the hospital, which is sort of the higher cost of medical care that we have. So highest cost.
Well, to peel the onion on that, so I'm noticing the DPCs and near sites are growing 10, 20% a year, depending on the year. Are large self-care companies driving that because it's a great complement to potentially reduce costs, or is it small employers that are driving it, or something else?
Yeah, it depends on the area of country you're looking at. I mean, DPC is throughout the whole country now. And it is growing. The last I saw was about 35% growth. So it's likely, we believe it's likely it's going to grow in multiples, double, triple, and we're trying to get ahead of that, as a growth strategy. But it just sort of depends because you have a lot of employers. There's some of the stats we get to later. Is about half of the employers with 3 to 9 employees have no coverage, no health care benefit coverage in their employment benefit package. And so this is easy for them. They can do something very affordable for their staff. But and I'm glad we're still on this slide too, because let's not forget, you can have all the direct primary care you want, and it's great and affordable, and it helps people with type 2 diabetics. It's 13% of our workforce, stay out of the hospital, but you still need something that covers when you go to the hospital, because that's a huge expense for families. Again, we know about 1 out of 20 people hit their deductible every year, but you need some sort of plan. It's either the high deductible health plan, like you said, Robert, it's a catastrophic type plan, even from the Blues that have those, or it can be something different called medical sharing. Most people have heard of MediShare. It's a medical sharing plan for individuals. They also have these medical sharing companies that are good for companies, for employee groups as well. And I will tell you that you have to be careful because they won't cover you if you do really crazy things. I mean, if you go and go to the bar one night and you get crazy and you do something ridiculous and hurt yourself or somebody else, you may not be covered under those. They're very behavioral oriented. So the rates are very affordable because it's a way of saying to people, if you have great behavior, we're going to cover you. You don't go out and do crazy things. You're married, you have kids, you go home after work. And those are the folks that are covered under these plans. So you have to be careful who you cover under those plans and make sure they have that coverage when they go to the hospital. So,
Frank, we got a bunch more questions. I'm going to hold them for time and let you guys proceed. And the next time you stop, I'll hit you with the next set of questions.
All right. Chelsea, what have I missed so far? You're muted, by the way. Okay, so maybe she's still muted.
Okay, sorry. It wouldn't let me unmute until just then.
Yep.
So I do like to share just working on the front end previously and something that I think is highly relatable. Either, I've seen in plenty of clinics where a mom comes in with 2 sick children and they need to check in, and you see the blushed little cheeks that allude to a fever and, the snot running down their nose. And you say, okay, well, your deductible is not met, so it's going to be $100 up front and any differences at the end of the visit. And so the next question is always, well, what are the differences going to be at the end of the visit? And you cannot tell them up front because it's all depending on what happens in that patient room. And so that's tough. And I've watched those same moms look down at their kids before. And I've seen it sitting in the lobby at facilities where they have to turn out and go outside and leave because they just can't afford it. And that's tough. That's tough for our employees. That's tough to see that for people. And so having that accessibility and the ability to go and not having the fear of, am I going to get a bill in the mail in 30 days? Are there going to be surprise costs? What does it cost me to show up? That's really tough. And then on the opposite end, for people who maybe financially are more stable and can afford it, you don't want to. If I go in and I've got a sore throat and I'm questioning, I don't really think it's strep, but just doesn't feel that great, let me just go rule it out, and they tell me it's going to be $100 up front, I'm probably just going to leave and go to Walgreens and buy some sweet flavored cough drops and call it a day and hope it gets better, because that's a lot cheaper. So just the accessibility and what that looks like. And then also, when you have insurance and you disclose that at most places, the contracting becomes a barrier because they'll say to you, well, unfortunately, you disclosed that you have health insurance, so you're now removed from any self-pay discounts. And then naturally, people, myself included before, we get angry with that. So you mean to tell me because I pay a ton of money every month to have this, I'm now removed from the ability to pay less? And the unfortunate answer to that is yes, you are. And probably many people here on this call have, related to that. So that's important to me. That's something I think that's relatable to everybody, as just that accessibility and understanding your options, and kind of when you remove that middle portion, what it can mean for your care, and you really have the choice. It's no longer just health insurance, it's health care. And I think that's important for everybody.
Awesome. Thank you, Chelsea.
Yep.
Yeah. Case in point, my son had an echocardiogram. When they get sports physicals, they might hear a murmur. Went and had an echocardiogram at the new MUSC Children's place right off Rivers. And the instruction here is make sure you ask. So we could use his insurance, which was $2,056 out of pocket, or self-pay, which was $300. It was a tough choice. I opted for the $300 self-pay. It's the same facility, same echo tech, same doctor reading it, same consult that we had afterwards and everything. So, I would say always ask. Particularly for employees in the work comp world. There are ways to get some of these direct primary care clinics will do workers' comp, work related, drug screens, injuries in the workplace, and all those sorts of things, which help as well to take care of your employees. But you need to ask. And once they have your insurance information, it's hard to opt out of that and be a self-pay patient. But you do have the choice as the patient as how you want to pay, as long as you do ask that. And transparency of pricing is important. Also bundling. So check with clinics when you're thinking about these options to save some money on your healthcare and increase their access to utilize healthcare for your employees. ask them about bundling. And what I mean by that is what's included. What's included, even a walk-in visit. We have a $97 walk-in visit that includes the EKG if needed, includes any x-rays that the doctor wants to order, includes the labs that are done in-house. If you're diabetic, it includes the A1C and the lipids, and includes a CBC for infections, even a couple of shots that you might need, a steroid and an antibiotic in the clinic. All of that stuff is included in the visit, and that's not always the case. Some DPCs have a very low model of a monthly subscription pay, and then they charge for those labs, they charge for those injections, they charge for flu and strep tests and all that kind of stuff. So that's a good way to dig into the clinic that you may be looking at and say, what's included in my visit? I don't want to disincentivize my employees to go to the doctor. I actually buy this stuff so they can go to the doctor. I mean, that's probably the most challenging part of this model is you pay, $25,000 for a family to have coverage shared with the company and shared with the employee, and then they just never use it. You think, man, there's got to be a different way. And again, I have to emphasize, you still need that major medical, that catastrophic hospital surgical coverage, because most people don't have, more than $1,000 in their bank account to pay for a $20,000 surgery or something awful happens. A quick aside, I like to say, if you're going to get hurt, do it in your car, because usually your car insurance is sometimes better coverage than anybody else, but we don't always have that option, right? So two major parts of insurance, the preventive care part and the catastrophic part, and you need both. There's a third part that some people throw in there, prescriptions, and there's cool ways to do that too. There's also Good RX. If you go to any of your pharmacies and you ask them for the Good RX pricing, they will give it to you. And oftentimes people found it's less than the copay you may have in your plan, depending on the type of plan that you have. So, but these are the two major models here: the preventive care and the catastrophic hospital care. And so all of this research to say, and Robert doesn't like this. This looks like our big pitch here, but there's a picture of our first clinic. It does have a few things that I think is helpful to address. The moniker at the bottom says fast, affordable quality. The reason that we have a very fast model is our doctors just treat patients. When you go into the ER and ask these ER docs that we know, they tell us they spend about 75% of their time in front of a computer documenting visits, putting in notes, and doing all this sort of thing that we don't allow our doctors to do. We have scribes for that. For every doctor we have 5 staff members. And so that's another thing to ask your DPC clinic in your local area. How many staff members do you have per doctor or per provider? PAs are also folks that are used a lot in urgent primary care centers. But they are simply fast because they don't do anything else besides evaluate, diagnose, and treat patients. They don't get into the EMR. They have a sheet that helps them record stuff, and it has a whole bunch of initials on it that they can circle. STP is strep, and so they just circle it. Somebody knows to do the test. So we make them very, very efficient so that people don't wait. That's how you eliminate the wait time in most clinics, is by not allowing the doctor to be a record keeper, a data entry clerk. You've seen some of these doctors typing with both fingers instead of both hands. They're not the most efficient ones. So the affordable part is we've eliminated the acceptance and filing of insurance. We certainly can give people receipts and they can try to file those with their insurance company, but by eliminating that 640 insurance companies that we had before, where I worked before at Health First, we've made it very affordable. We've cut our costs, so we pass that on. And then the other part is the quality. So, of course, that stands for FAQ, by the way, but we just had a little fun with that. Fast, affordable quality. so you can remember it. But all of our doctors and PAs have been trained and have experience in the ER. So when you're looking for a direct primary care clinic, typically you'll find they have primary care doctors. They typically have not spent time in the ER. They may be just absolutely fantastic, and they know you. They've known you for years. People say, can you guys be our regular doctor? And we think, yeah, we hire regular doctors as well. But ours all have ER training, and so they walk in with ER eyes, meaning that they look at you and they figure out that you're not getting ready to have a stroke, that it doesn't look like you're having a heart attack, that there's no meningitis, there's nothing really scary and deadly and challenging in your presentation. And so now they can just treat you for the symptoms that you came in for. So that's just a cool thing that we like to do with all the folks that we hire. And that sounded like a commercial, Robert. So we combine some of those models we talked about. We combine urgent care, direct primary care, and the near-site medical clinics because I think it's cool to do it in one facility. Again, it cuts the cost doing direct primary care. I'm going to fly through some of these because this is now this is interesting. We'll sit here for a second because direct primary care really does help keep people out of the higher cost model. Even in that, you want to have a DPC clinic that has specialists that they have already chosen, handpicked. And if you're using that direct pay model, you want to have them have pre-negotiated rates for things like CTs. We have 2 groups here in town, imaging specialists and tri-county radiologists, that we can get $270 CTs from, instead of you paying $800, $900, $1,200 somewhere else. If you come after 5 o'clock, you typically, and you need one stat, you may go to the hospital and pay that higher cost. But there are folks here in town, even a $300 MRI. So you want to look for those specialists too, because you wonder, it's great to have preventive care, treatment, urgent primary care, but what if I need a specialist? What do I do next? So this is, let's see. So let's talk about, I'm buzz through these. Gerald's for a moment. And first of all, if you're looking at direct pay models, individuals have one pricing structure, like the concierge docs that are charging about $150 a month. If you don't take insurance and process insurance and you cut out half the cost, the price drops by half. And then for companies, we've done it even less, half of that. So for an introductory type rate. So pretty cool to be able to offer that as a benefit to your employees, keep them healthy. Again, the video medical visits are included. We even added a drive-through that came out of COVID, right? We pivoted during COVID to people don't want to go inside anywhere. We've done over 10,000, almost 15,000 COVID tests in a drive-through. Not one of them has come into our clinic. Not one of our employees has been positive for COVID or caught the illness either. Either we have really strong immune systems or there's some cross antibody connectivity with the common cold. It's also coronavirus, or it's been done in a way that keeps the patient in their car, in their bubble, if you will. And with the PPE on our staff, no one has contracted COVID-19 in our system, which is really cool. We almost have a study of almost 15,000 test cases done with anywhere from 7% positives to almost 12% positive rate. So that's, 1,000, 1,500 people have been positive for it that we've been exposed to, but not contracted the illness. So we use that drive-through also for flu tests. You can get a flu test if you're a member for no charge. Stay in your pajamas and do a drive-through if it's not something that can be handled over a video visit. I want to talk about let me get to there you go. So Gerald's Tires, they have switched their model for all their new employees coming in, as well as offered to their existing employees either the traditional model or our model that's included. And it has saved them 42% on their out-of-pocket costs, from over $500,000 to about 300. And most of that savings went to their employees, which they were just absolutely excited about. If anybody knows Bill Watts here on the phone, he has such a heart for his employees. And so over 80% of that savings was direct to his employees, saving $400 a month for their family coverage and everything, which is really cool. So still have the same coverage of preventive care, catastrophic care. They even added a pharmacy benefit for $30 a month that has 300 different medicines offered for free. That's not part of our plan, but the structure that's put together, there's some really cool agents out there, healthcare agents, that are looking at these different innovations, trying to save companies some money in their premiums and their out-of-pocket costs. And you can put all the benefits together that you have in a traditional plan, just for less money, if you do it right. So Gerald's been pretty cool case study for us to go through. Here's the slide that talks about the 82%. This is the national average. 82% of the cost of health insurance has been borne by the employer, and 18% by the employee. So typically, at 82% is about $6,000 of a $7,200 expense per employee, and the employer bearing most of that cost. Again, if each employer was saving $6,000 a year, dream about what you could do with that. Could you have an HSA for your employees? Could there be pay increases, more development plans for them? We like to pay for half of the counseling visits for any of our staff that need it. So when they go to a counselor for, mental health is going through the roof right now with isolation and all the stuff from COVID, and the fear that's out there from this illness, this real disease. And so we cover half of that. So it's kind of fun to be able to use some of those savings to do. We provide lunch every day for our staff. So that's kind of fun, a way to come together and break bread during a 12-hour day. It's a good break to do that as well. Robert, I'm thinking about stopping here. We're almost out of time.
Yeah, you did a terrible job stopping every 10 or 15 minutes for questions. I have a few questions. I'm going to hit you rapid fire.
Yeah.
You have 30 seconds per question. First question, your company, they're located, you mentioned the low country. Question from somebody was, are you in other parts of the state?
Not yet. The plan is to continue to build out Charleston this year and next. 2 this year. The plan is for 4 clinics next year, and then Greenville-Spartanburg is after that in 2022. Question
2 was, and you covered this. This was real early on, but you may have covered part of this. It was around referrals to specialists, and it sounds like that you do that when you are negotiating relationships with DPCs, you need to make sure that they have established relationships with, and that if this is let's say you're self-insured and you have this plus a high deductible plan, you'd have the DPC and your carrier for the high deductible plan ensure that you're referring specialists to people in network. I assume?
Yeah. We pick the specialists based on the quality and the reputation, like somebody like Charleston ENT, Low Country Orthopedics, and so forth. So we pick them up, and then we sort of require them, if we're going to refer them business, to have these self-paid discounts, to have access to care at certain times, not just during the week and on the weekends as well. So we want them to coincide with our hours that we're open evenings and weekends also.
Give me the it sounds like if I'm a small company and I have nothing now, I'm not required to have anything now. There's a use case. And if I'm a really big company and I do have the I have legal requirements because I'm greater than 50 people. This can be a compliment. Can you talk about the small business use case, like, and where this might make sense for larger companies?
Sure. Yeah. And Ledford's is a good example, about 20 employees, and they're not obligated to have Affordable Care Act standards met in their workplace. And so they can add this, and either they add the catastrophic hospital high deductible plan separately, or, spouse may have a plan or something like that. They may go to healthcare.gov and get something for catastrophic needs. But this is a way for them to offer a benefit, a health care benefit. It's not health insurance, but it gets them into that area where medical services, their employees can go get care when they need it. The larger companies, again, the self-insured type folks love this. The ones that have more traditional plans are paying, pretty high amounts for that traditional care. And so it's hard for them to add cost on top of that. So for them, it's more difficult unless they get creative and they decide to do a much higher deductible and try to save some premium dollars and then add this. But they still need the preventive care for their employees, because the employees are not going to the doctor when it costs them $250 out of their pocket. They're just not doing it. So,
Frank or Chelsea, last question I'll pull just for time is around telehealth. Are you seeing that grow? And how is that a part of this near center or DPC? What do you see as the future of telehealth?
Yeah, absolutely. The answer is a big yes. So I started doing that because people weren't coming to their clinics. So everyone now has telehealth. We call it video medical visits because you're on the doc on video. Super easy to do from your home, from your workplace. As long as you don't need an x-ray or draw blood or an injection. We haven't figured out how to do that remotely yet by phone. We do the testing. We do have drive-through testing. You can use that mode of medical care as well. But it's going to grow. It's going to keep growing. Right now, when you do medical care for somebody, telemedicine, you have to have a doctor that's registered in the state in which the patient resides. So you can be traveling in Arizona and call our video medical service, or call your own video medical service and get care because you reside in South Carolina and that doctor is registered in that state. So at some point, legislation may allow, a doctor in South Carolina to see any patient through a video medical visit. That would be a legislative win for the patients and the doctors.
Well, this was a win for us, Frank and Chelsea. This was a fantastic presentation. This has kind of been emerging on my radar. It's been around forever, but just sort of emerged. I had this is part of a conversation with our broker. I'm looking at Nathan with Gallagher. He's mentioning in the comments that he's moved more clients than ever to DPC. So it's been part of the conversation. So I thank you for just indulging me and educating me and the rest of the members on what's this all about and where this might make sense, and equip us to have conversations with our partners about this. So I really appreciate it. I'd also like to just say thank you for you and your staff being on the front lines. There's a global pandemic, and your team is on the front defending the whole country. And so we just appreciate you and all medical professionals. So thank you very much for all that you do.
It's a pleasure. Our team is awesome. Yeah, they're fantastic.
I thought that was cool. I read in the paper a while ago, you guys were offering free care to those that had, I believe, in the hospitality industry that have been affected by closures of businesses. I thought that was pretty cool. So you're good people, and I appreciate what you're doing. If nothing else, I wrote down, and I feel like I'm a good negotiator, but I've never, and I always check prices, and I check GoodRx, and I check facility costs, but I've never asked, do you have a direct pay, self-pay, before telling them I have insurance. So I feel terrible that I've never known I could do that. So I've now got a new negotiation tactic, and I'm looking forward to using that. So thank you very much. And folks, this was recorded. If you want to check it out, I'll send out the presentation and Frank's contact information if you've got any follow-up questions. Please like, share, and comment on my post in LinkedIn. And everyone have a wonderful day. Thank you, Frank. Thank you, Chelsea.
Thanks, Robert.
Thanks, Robert. Thanks, everyone.